got a problem though. I think I'm not sure you're going to know which made the difference if people do better. I think we've been hearing that a one size fits all has gone as far as it can go. And I'm a great fan of genetics. I'm a geneticist. I take care of people with genetics problems. Not only that, I actually think molecular studies of disease are going to help us hugely in understanding better, giving us better classifications of disease, the complexity, for example, of diabetes, which is many different diseases, new potential opportunities for developing innovative drugs, etc. Strong fan of that. But I don't think we need the data cloud to tell us what the most important actionable elements in our healthcare or maintenance of health are most of the time. I would just challenge you in the audience. Could you generate a list right now, pulling out a piece of paper, of things you could do to assist your health? I want to speculate that you could easily do that every single one of us could easily do that. And a lot of what we're talking about, as I think is acknowledged here, is the toughness of changing behaviors, often in a societal environment that is kind of pushing against what we need to do to be healthy. It's easy not to go take a walk because we can drive our car to work or get off the bus very close to work. It's really easy not to eat what we the way we ought to be eating. In fact, it's hard to eat the way we ought to be eating. Our social networks are potential part of the problem or potential part of the solution. And that doesn't matter whether we share genes with our social network or not, because most of what we need to do to live healthier, we already know, and what we need to do is overcome the barriers to doing it. One of the hypotheses of P4 medicine and similar personalized genomics approaches is that knowing that you have an increased risk of type 2 diabetes will be the magic motivator that gets you over the hump into an exercise pattern and a healthy eating style. But actually working on a day-to-day basis with individuals strongly suggests that working with your community, with your social community, to figure out how to support each other is likely to be a very effective strategy. So I say these not to ding the notion of the wonderful advances that will come from a better molecular understanding of disease. I'm there, I agree that they will be there, but we need to be humble. We need to clarify what comes from the data cloud and what might be much more cost effectively approached in both effectively and cost effectively approached in other strategies. Why does that matter? Because there's lots of opportunity for investment in medical products related to the data cloud, and nobody's terribly interested in investing in coaches to assist you and your social community to eat healthier or exercise more often. We have to think about how we're allocating societal resources here.
So actually, that is part of the challenge. The way medicine is set up right now, the financial or incentives are to deliver products and to deliver procedures, and that's what you're compensated for. There is very little compensation for outcomes. And so what we really need to do in personalized medicine is work with groups that really do have a financial interest in population health and outcomes. And so both Ohio and Peace Health are examples of groups like that. Ohio is the healthcare provider for almost 70,000 people, its employees. So if that group is healthier, if they have less rates of disease, that has an absolute bottom line impact for Ohio. And that is one of the things that motivates them, is to do what it can to make its population healthier. Peace Health is in the same situation. It's a healthcare provider of last resort for a number of communities, so it gives about anywhere between $200 and $300 million a year of uncompensated care. So it wants to reach out to the community that it's serving and make them healthier. That will have a bottom line impact. And so to really make P4 medicine work, I think we're going to have to realign our financial incentives a little bit. so that the healthcare system is not focused on simply selling products and selling services, but has a vested interest in population health and in outcomes. And once that's done, that will lead to, I think, a much more efficient allocation of healthcare resources. That's an important component of this. And so I would want to clarify one thing. I mean, we never for a moment think that simply knowing that you have X chance of developing X disease is going to motivate people. I mean, experience and study after study tells us that it doesn't. But what really does motivate people, we think, is when you reach out to them in their families and in their networks. When you don't try to change just one individual, isolated, pulled out of context, but you reach out to their social context and try and change it that way. That, we think, is going to have a considerable amount of power. And so you reach out to people individually, and maybe they don't care if they come down with type 2 diabetes. They'd rather eat the Big Mac right now. But if you approach them in context of their families, and there's discussion about the impact of the families, if other people that care about them become involved as well, if you mobilize them as groups, then you have a much better chance of getting behavior. And if you give those groups a lot of information, as close to real time as you can get, so the progression towards type 2 diabetes is just not an abstract, oh, you have X chance, but it's a continuous flow of information that tells you, and not only you, but the people who care about you, you now have taken one step closer to type 2 diabetes. You've now taken another step closer to type 2 diabetes. I mean, there's no reason why we should not do this, and I think molecular data can really be powerful in that kind of context. So we have to combine new ways of reaching out to people and engaging them, and new ways of drawing them in to participate with the molecular data and with other kinds of data, and start using data more effectively socially. And this is a new frontier. I cannot point to you to studies that show that it works. But reaching out to people in this way is working in a lot of other arenas, and there's no reason not to think it won't work in healthcare. And I do believe that the power of data is really strong. It's just that it hasn't been mobilized, and it hasn't been distributed, and it hasn't been processed socially, because we didn't have the capability of doing that until really quite recently.
All right, that's wonderful. I agree with both perspectives. I wanted to say that sequencing genomes isn't cheap, and so we know that there's going to be people invested in technology, on the software end. Additionally, you have to store this information. We're talking about, at minimum, 3 gigs of data a person per genome. And that begs the question that, upwards of, even though the price of sequencing technology is decreasing, we're looking at thousands of dollars here. So I think it's contextual in the way that we approach disease ethology. I think it's like, okay, we can either sequence one individual's genomes, or we can hand out 100 mosquito nets and 100 packs of condoms. It's contextual to the disease itself. But moving on, that kind of segues into my next question, which is, if we were to look at the social and equity considerations, and we look at socioeconomic status with race and gender, for example, I mean, in the United States Constitution, we say that each man is created equal, but if somebody has 10 more genetic variants that contribute to a disease, that's kind of a burden on our healthcare system. Although I don't believe this, I'm just saying this as the devil's advocate here. How do we eliminate the potential for this social stratification and, like an Aldous Huxley type of scenario?
Well, I think you're putting on the table a couple of things. I want to say that science, to some extent, offers a protection because we will all carry gene variants associated with risk of common complex diseases. So I think there's a likelihood, as we have more genomic information on more people, that there's some equalizing that will occur there. But I think you're raising two issues that are certainly here as we hear a vision like the one we're hearing about people being surrounded by the information cloud. we have a hypothesis that that data properly managed will result in better health outcomes. It's a hypothesis that's worth testing. But it's certainly a hypothesis, it's certainly a model that carries concerns about privacy and concerns about what in medical ethics we call non-maleficence, the concept of first do no harm. So in terms of privacy, I think we've just heard described a rather intrusive system in which basically getting health care equates to having lots and lots of data taken about you and then given back to you in a cloud around you, but also submitted for those large-scale studies with large populations. So at minimum, we have some interesting questions about how voluntary that process is going to be. Our traditional bedrock of research says that participation in research should be voluntary. Are we raising a specter of you don't get to get health care unless you participate in this big experiment?